Good afternoon, everyone, and welcome to Ending Stigma and Unlocking Resources, Session 1, Words Matter, Removing Stigma from Addiction. My name is Laurie Smith, and I'm the Community Initiatives Coordinator for Atlantic Prevention Resources and coordinate Join Together Atlantic County, a substance misuse prevention coalition, and the Atlantic County Opioid Task Force. I would like to thank our sponsors for today's event, Atlantic Prevention Resources, the Atlantic County Division of Public Health Substance Abuse Services, Seabrook, and Atlantic Care. Specifically, Brian Wilson, Jennifer Peelhow, Sean Collins, and Dylan Worldeck of those organizations who helped put this program together. All are members of our coalition and opioid task force and are working to help reduce stigma and opioid misuse here in Atlantic County. This is part one of a two-part series. Our second event will be held June 23rd from 4 to 6 p.m., where we will be discussing stigma and opioid prevention, treatment, and recovery resources within our county. We will be recording the presentations today to make them available for future viewing. And when each presenter has finished, there will be an opportunity to ask questions. If you do have a question, please put it in the chat box and they will be shared with each presenter. At the end of today's event, there will be a link in the chat box for an evaluation. Please complete that evaluation so we have feedback for future presentations. At this time, I would like to turn it over to Dylan Worldeck of Atlantic Care to introduce our first speaker.
Thank you, Laurie. As Laurie mentioned, my name's Dylan Worldeck. I'm a project manager with Atlantic Care. I'm a part of the JTAC coalition as well as the Opioid Task Force, and I'm really excited that we're able to have this conversation today and start moving the tide on stigma in Atlantic County. I have the pleasure of introducing Gloria Seal, who is the Senior Director with Atlantic Care Behavioral Health, and she oversees substance use services, outpatient services, adult partial care programs, community social service programs, the whole gamut there. She's a licensed clinical social worker and a licensed clinical alcohol and drug counselor with over 15 years of experience in the field. She has specialized experience in medication-assisted recovery, opioid treatment programs, criminal justice, and community-based programs. Gloria is one of my favorite colleagues here at Atlantic Care, and she's a wealth of knowledge on this incredibly important topic. So welcome, Gloria. Thanks for joining today, and I'll turn things over to you.
Thanks, Dylan. And thank you, Laurie, and everyone for having me. I'm excited to be here today. I appreciate the opportunity to talk about this topic. I think anytime we have the opportunity to talk about stigma and the impact that our words have on communities and individuals, I think it's always a great conversation that we can engage in. So I'm appreciative of being here. I want to, start out today kind of talking a little bit just about the fact that normally we would jump in and talk a lot about how substance use and addiction and treatment have gotten to where they are today and kind of the historical context for it. But that's sort of a long conversation, and we're not going to do that today. But know that there's a lot of information out there available. We're going to sort of jump right into the conversation about stigma and about words and language and go through what that is and how that impacts things, and then also really jump into some more tangibles of like, what does this mean for everyone and what can we do and what part do we play in these conversations and in taking accountability and responsibility for changing some of what we do and how we show up. So I want to start out just by asking each of you to kind of go back and think about, I don't know if it's grade school, middle school, high school, sometime back in your memory when kids maybe aren't always the nicest. And I want you to think about a situation that you might have found yourself in where maybe you felt different or excluded for some reason. And I just want you to sort of draw on that memory and those emotions and those feelings. I think it's common, especially during school age. I think it happens to adults as well, but especially during school age time, to feel somewhat excluded for some reason and different. And I can say for me, growing up, I've always been athletic. Sports have always come naturally to me. And for a long time in my life, that was something that when I was very young, helped me make friends. It helped me engage with people, being kind of quiet and introverted in a way. It helped me get involved with people because at recess or during gym class or whenever, people wanted me to be a part of things. I was someone that somebody wanted on a team or wanted to be a part of the game that they were playing because I just was good at it. And that worked out really well for me through my life. But as when we're younger, right, and at least in the time that I grew up, there's a period of time, an age where you reach where I think kids start looking at things through like more gender oriented lenses. And there was a time where I was everybody's best friend. I got picked for teams. I got picked first in whatever kickball. And then there was a period of time all of a sudden where it wasn't so cool for a girl to be the best basketball player out there. It wasn't fun for everybody that I could, play football better than they could for some reason. And I started to feel a little bit different during that time. And that was at a pretty young age, right? When those start changing, girls were over here doing one thing and boys were over there doing another. And I've never really fit into constructs very well, which probably speaks to some of that as well. But, I started to become cognizant of the fact that people saw me differently and that started having an impact on what I did. I used to be the person people waited for to pick teams. And all of a sudden, I started coming out and seeing that games had already started, or there was no room for me on a team, or I was going to make the teams uneven. And so I couldn't play anymore. And whatever reason it was, right? And right around that same time, I remember that we were practicing for some sort of like rehearsing for a school play or something like that. And everybody was in the hall getting ready for this play. And we were all, all the different grades, lots of kids in the same place all around. And somehow as an understudy, someone got sick and I ended up having the opportunity to be like one of the main people in this play. And I was rehearsing. All I was doing was walking, right? That was my role. I was supposed to walk from one spot to another spot. And the teacher in the middle of kind of the rehearsal, and me again at a very young age, like I was probably 7 years old or something like that, jumped up and came running across the room. Stop right now, right? You're walking across here like you do every day, like you're a football player just walking off the field. You need to act more like a girl. You need to learn to walk more like a girl. You're playing a girl in this role. That's what you need to do. And I remember very distinctly, like even as I share that experience with everyone here, I remember the knot in the pit of my stomach that came out of nowhere. I remember feeling sweaty. I remember my face flushing. And I distinctly remember all of the kids around me laughing as this teacher is sort of berating me about how I'm walking. And all I thought at that age is, I'm just walking. Like I didn't do anything different. I'm just walking. And that's sort of a simple example, right? But I think it's one that other people can think of similar things that have happened to them as well. And it's just around something that I was doing naturally that I didn't necessarily think about. But I think it's common for people to be able to go back to their school age years or different times in their life where somebody sort of called them out for something in that way and identified that they were different for some reason. I don't think that teacher ever had any intention that that would sit with me for as long as it did, or that it would come up into my brain as I was growing up thinking about, am I acting the way I'm supposed to? What are people going to think? Is the way I'm acting conveying a certain message to other people? I think they were trying to be helpful and give me some feedback about how I was rehearsing in this play at 7 years old, right? But the words that people have and the words that people say last with us for a long time. And such a simple example, right? Completely unrelated to the topic that we're talking about in substance use. But the words that we say to people impact what they go through and the way that they manage their lives down the road. And that has an even greater bearing based on the environment that we're in and the other factors that are coming into us. And so I point that out because I just want everyone to take a minute and use that as an opportunity to kind of center yourself around an experience that you've had like that, or that you remember having as we go through this. Because one of the things that I think tends to happen for us is that when we think about stuff like that, that happened to us personally, we often are able to relate to this. And we're often really cognizant of the words that we use, and we're aware of the language we use, and we're aware of not trying to offend someone or to do something in the right way. But often we get disconnected from that individualistic concept and seeing people as people and talking to people in that way. When it doesn't pertain to us in that way, when we're not feeling those emotions, which is why I want you to think about how your body reacts when you think back on an example like that. And I remember not liking feeling that way. I remember feeling uncomfortable. I wanted to run out of the room. I didn't want to be there anymore, right? But I couldn't do any of those things because I didn't have the control and the power and the authority to be able to do that at that age. So use that to sort of be grounded in as we go through this. And I think it's important to think back on all of those things. You know, I have all these quotes up here just to, again, sort of solidify the point that I think we know deep down that our words matter because we've been through experiences like that before, or even recently for some people, right? But we get so disconnected from it. And you can see in this that we can do a better job of being a little bit more aware, and that we can be a little bit more cognizant of how we're treating each other and remembering to see people as people. I think it's important to also just sort of give some definitions as we're going through this. And so, you know, what this whole conversation today is about stigma, right? And that's really this concept of, like, you know, at least what the dictionary defines as a mark of disgrace, right? It's usually a quality or a circumstance or a behavior or something that we sort of ascribe to a person or a group of people. It often doesn't have a positive connotation, right? It's something that's got a negative connotation. We often think about it as something that's undesirable, right? We don't typically stigmatize people in really positive ways and then talk about all these great things about them. They're usually things that we think of as undesirable. They're labels, they're stereotypes, right? And we've got some of the examples that we tend to see out there on the screen. Again, this sort of goes back to my point that I made previously, that oftentimes when we're labeling someone by their substance use or any other reason, right, mental health or something else, we're no longer seeing the person as an individual. We're no longer seeing that person as a person. We're now seeing that person as a part of this stereotype group, or as an object, or as maybe a nuisance or a barrier. And so the human factor comes out of it. And that's something, again, that as we're in this field and as we're doing this work, that's very important to everyone, is really important to get grounded back in and be reminded of. I don't know that anybody gets into healthcare or behavioral health or advocacy or being a recovery specialist or a peer or whatever work you do in this role. Nobody gets into it because they don't care about people. Everybody gets into this because they care about people as individuals and that want to create a warm and welcoming and supportive environment for folks. And so, again, thinking about that as it relates to stigma. Also in relation to stigma is this concept of discrimination, right? And so that pushes it into unjust or prejudicial treatment of different categories of people, right? Again, dictionary definition. What's this mean? This means actions, right? So when we talk about stigma, we're talking about these concepts, these beliefs that people have that are dangerous and detrimental. Stigma is what leads to discrimination. And I think oftentimes something that we do is we talk about what we're doing as stigma, right? Let's reduce stigma, let's do this, let's do that. But what we're actually combating or what we're coming up against is sort of outright discrimination. What we're talking about in this are the actions that come because of the beliefs that we have about people. So the beliefs and the labels and the stereotypes are the stigma, but the treatment that people get and the actions that we take are what lead that to discrimination, right? And that has to do with the things that you see up here. They might be somebody's not eligible for housing because they use substances or because they have a criminal background or because they have a mental health diagnosis, right? It's not having access to certain services because of your background. It might be hiring practices that exclude somebody that has a history of using substances. Or have a criminal justice background, right? Or a background with criminal justice. Mandatory minimum sentencing. Those are all things, right? Policies and practices that we have in place that directly impact individuals who are using substances. Or other groups, right? Like this could go across. If we did this bigger than substance use, this could be, you know, a days-long event. But looking at that and trying to identify how do we combat that discrimination, and remembering that I think, again, we're here talking about words and how words matter, being really clear about what we're talking about when we're in the moment, right? And when it's stigma and beliefs and how we sort of combat that or come in and engage in a conversation around that, around someone's beliefs that are usually based in misinformation or a lack of information or a fear of something, right? And can we have conversation around that to help correct for those stigmatizing or stereotypical beliefs that someone has? But the intervention for when we see discrimination might be very different than what it is for stigma, right? And we might not do those same campaigns. Some of them might align, but I think it's really important that we identify that and that we start sort of calling that out or identifying that as a collective group as it's happening. and get some energy behind what are the next steps behind what we would do if we see discrimination versus stigma, and what are some things that can happen to help support changing the culture, changing the language, changing the work that we have around that. Why are we talking about this, right? So, we're talking about this because within the past, 4 years, there were some surveys that went out and nationally and identified that about 75% of people out there in our society believe that addiction is a choice, that it's a choice that somebody makes, right? Even with all of the information that we put out sort of on a regular basis, or that's been coming out even more recently around this being, we use a medical model, it's a chronic disease, right? All of that language that we try and use around substance use, there's still this very strong rooted belief that addiction is a choice. That, balanced with the fact that more than 23 million Americans are affected by substance use annually, right? So we've got 23 million Americans affected by this in some way, yet 75% of people believe addiction is a choice. That leads to very few numbers of people that are actively receiving and engaging in treatment, right? Like 11%, it's typically less than 11% that end up in some sort of treatment. And there's lots of reasons for that. And I think, a lot of people on this call are well aware of what all of those things are and where we see it, right? It could be the fact that somebody is showing up to their medical provider and they're getting, dropped from care because of something that's in their urine drug screen, or because of something that they've been using or overusing. And instead of getting into treatment, right, they're dropped from the practice. Or it could be the way that they're treated if they go into an emergency department or an urgent care and maybe aren't given the same level of care or quality of care or the opportunity for care because they're known to people because maybe they've come in there more than a number of times, right? So there's a lot of different ways that this plays out in terms of how it creates like a lack of access. The lack of access isn't necessarily because there's no treatment available. The lack of access is because the people don't want to go in, or they're turned away when they do come in. And that's not necessarily across the board all the time, but is a very common thing that we see happening. And so we have to, again, continue to have this conversation around how do we change the language that we're using to try and get more people involved? Where do we get most of our messaging from? We get a lot of our messaging from the media. That is one of the most common places that we get inundated on a daily basis, right? We get it from the news, we get it from TV and film, commercials, we get it from social media. That's one of the biggest places right now that information comes out, whether it be active information coming out or ads that people are seeing. And one of the things that is most commonly portrayed in the media are these like negative portrayals of somebody who uses substances, somebody that uses drugs, right? We see like a flyer or a commercial or a billboard or something that has somebody that is like shaking and laying on the ground in the corner of a floor, or a table that's got needles and spoon and drugs laying out on it, right? Or somebody that's actively using. These are the images that come across media most consistently that are portraying that. And so if the sort of masses are consuming that type of media, that's what everyone's seeing. That's what starts laying pathways in people's brains to say, this is what someone who uses drugs looks like. What we know, again, look at these numbers, right? More than 23 million Americans are affected. I'd ask anybody on this phone to throw a rock and find somebody who's not affected by substance use in your life. We know that it's everywhere. It's not just this subset group or this group over here. And so yet the media continues to put out messages that use stigmatizing language or images that are stigmatizing or demeaning or portray somebody as dirty or scary or mean, when we know that anybody or everybody could be affected by substances at some point, right? It's something that doesn't discriminate amongst people. It doesn't care how much money you have. It doesn't care what sort of affluence your family had. It doesn't matter what neighborhood you grew up in. You run the risk of being impacted by substance use in some way. And we know there's all different channels that people get sort of indoctrinated in use. And so what we want to do again is try and change that messaging. How do we get different messaging out? How do we get, people that are, wearing suits, or our leaders, or our, people in elected offices, or might be serving us lunch somewhere, or might be our neighbor, or might be our family member. How do we get images of all of these individual people in the media to be present, as opposed to these kind of dark, dirty, scary, I'm going to say, media images that are being portrayed? How do we flip that around and really push that out? And I think part of that is on us. That's something that we can all actively do, is take ownership over some of that in order to try and ensure that we're putting out the right messaging and we're putting out the right marketing materials that project that in a way that will change what people are then consuming and how they're seeing these concepts come across, which will change how they present the concepts when they're talking about them, right? The other thing that we do is we often set the stage for stigma within our own recovery communities. We have to be really mindful, or it would be ideal if we could be really mindful about not narrowing what recovery is so that it's just one way or just another way, right? One of the things that we've learned over time is that there are many routes to recovery, and that we want to help individuals find what route works for them. And I think Dr. Ranieri is going to talk about stigma a little bit later with it, as it relates to like medication assisted treatment, but those are some of the areas where we create limits. If you look at some of the research out there, you can see that people who define themselves in recovery do that in many different ways. So when they've been when somebody's been surveyed about how do you define yourself in recovery, what does that mean? Do you define yourself as fully abstinent? Only about 50% define themselves as fully abstinent, right? Compared to, do you define yourself as in recovery because you're fully abstinent from your primary drug of choice, but maybe you're still using other substances, or you're not abstinent at all. So there's multiple ways that people can define this. And I think one of the things that we talk about, and that's important to talk about, is allowing people to define recovery for themselves and not having sort of society or us as individuals define what someone's recovery should or could look like, but helping define pathways that work, right? That might be mutual aid groups, that might be medication assisted recovery, that might be none of those avenues. It might be formal treatment, right? It might be a residential program or an IOP, but helping to try and open those doors so that people have access to all of those different options that are out there. And again, incorporating those into the language we use when we're talking about what recovery looks like, as opposed to, I think, where we get ourselves pigeonholed at times, which is what we think recovery is supposed to look like, right? Or what recovery isn't. And that gets us narrowed in on that view. So what can we do about this? What can we do? And this is the part that I like talking about. You know, some of you might have seen these flyers before, but this is really something very tangible. This is something that can be changed sort of right on in the time. And it's sort of just as simple as, again, changing a word. It doesn't mean we always get it right all the time. We're people and we're going to make mistakes. And sometimes we're going to slip, or we're going to say something that maybe came out a way we didn't want to, but it's about identifying that that wasn't what I meant, or this is the word I want to use. So again, you can see right off of here, it identifies, you know, some of the older language, I'm going to say, are the negative or more demeaning language that's out there, and gives options for what you can replace that with, right? Addict, alcoholic, opioid addict, those are things that we want to stay clear from. Again, let's think about what we're trying to do. We're trying to see people as individuals across the board, everyone, right? And what helps us do that is identify people as people, right? A person who uses drugs, or a person who has a substance use disorder, or a person with a diagnosis of a substance use disorder, right? It's about the person first, as opposed to this label or this identifier that's put on them that then they sort of become, right? Or that we might become by having that identifier put on us. And so it really just is as simple as flipping these out. And again, I say it's simple, but note that that means that this takes time and practice and effort, because we have to be purposeful about changing that language. The view that you see on your right side is one that sort of lays out the fact that there are different times where people might use different language, and that we can identify that. And what this really calls out is this concept of somebody's right to self-identify. And this is in all worlds, right? Not just within substance use or mental health, but it's in any world, that I have the right to self-identify however I want to identify. So whatever language I want to use to call myself, I get to do that. But guess what? You don't get to call me that. And we know that in some realms, but for some reason in recovery, we don't necessarily share that. We just sort of pick up the language somebody's using. And so this kind of lays out like where some things might be more appropriate to use that and where they might be less appropriate to use it. And we want to stop using that language. But remember that someone gets the right to define who they are and identify themselves. We still have to be mindful of using appropriate language that doesn't use some of this more negative language in our recovery words. So what I leave you with is really this concept of asking everyone here to commit to change one thing. That's it. Not everything. Nobody has to be perfect, but change one thing. Identify one thing you can change. Change could be on an individual level. It could also be on a larger organizational level or like a team level, and identifying what to do. I put some examples up here of things that have worked well with people that I've seen doing this. Some of these things are things I've done. Some of these things are things that we've done as our organization. But the ways that you can look at how are we how do we have an opportunity to change the contribution we have that's negative, right? How can we flip that and make a more positive contribution around our recovery language and the impact that we're having in the field of substance use, in the field of recovery, and be a positive contributor and show up the way we want to show up every day that we come to this. So I leave you with those examples, and I ask that you think of one thing that you can change. And I think maybe there might be some questions. Dylan, I don't know if you saw any questions come through during this time.
Yeah, I did. Actually, a lot of them were answered in the presentation, so good job anticipating the questions there. One of them specifically was around, what about people in recovery? Should we try to convince them to change their language when talking about themselves? I don't know if you want to go into any further. I know you just kind of mentioned it, but that was the first question there.
Yeah, it's a great question. I think one of the interesting things that that we can always talk about is it's important for us to, what's the concept? We can lead a horse to water, but we can't make it drink, right? I think anytime we try and get into the realm of convincing people of stuff, we probably have gone off track. And so I think, again, it goes to understanding and sort of being open to hearing where people are coming from. And I think if we open ourselves up in kind of a vulnerable way and just gain some understanding for why do you choose to use the language that you choose to use for yourself, and gain some understanding around it, it puts us in a better place than necessarily trying to change that. Because again, for some individuals, using specific language, right? Like if I identify myself as an addict, that might help keep me on track. It might be the reminder I need to think about where I've come from for myself. Other people might have different reasons they choose to use the words they use, and they have different connotations depending on what circle you're in, or maybe what generation you grew up in, or when you started your recovery, or what your home group looked like, right? There's a lot of factors to that. So I would say we want to stay clear of necessarily trying to convince people of things, but instead let's gain some understanding about why we are using certain labels for ourselves and how we identify, and just start the conversation there.
Great, thank you. The next question is around families and what things families can do to help reduce stigma for those. I know there's many people that have discussed that there's concerns as a family member. What do I do in these situations? That sort of thing. Am I perpetuating stigma or any harm? Sort of thing.
Yeah. I think being in the place of a family member, there's probably so many answers to this question. And I think, being in that place can pose a lot of challenges. Again, I'm going to say that having a conversation, with your family member around kind of what information they want out there and what can be shared and what makes sense to share and what sort of language to use. I think being really mindful to sort of have conversations about this though, right? I think, part of what comes from stigma is this concept of shame. We're in this place where we hide things, and it goes back to that concept that the messaging that goes out is this doesn't happen to everybody, right? That's sort of the message, but that's not the reality. We know that you could look left and you could look right if we were all in an auditorium, right? You could look left and look right and think that it's likely that at least one of those two people, there's some interaction there with substance use in their immediate family, their close friends. And so again, I think it's about sort of normalizing the fact that this is something that's out there. And the more we try and hide it and shame it, the more it's going to stay hidden and end up resulting in people dying. Like that's where we are right now, right? Is that this is leading to people dying and people don't have to die. So I think having those conversations, talking about what information is comfortable for them to share, having an agreement about how we want to share this information and what it is, so that we're not just sharing it kind of willy-nilly, or that we're using language that doesn't feel comfortable. I think as family members, not being the person in recovery yourself, it is important to be able to use some of this language that we're talking about and to speak up, right? See something, you say something. You see something that's not right and we say something about it. Most of the time we just sort of sit back and allow people to keep doing it because we're nervous about what somebody's going to think about us. And I know that that can be hard to lean into. But again, I think if nobody's going to speak up about something, then nobody's going to speak up about something, right? Somebody has to take that first step and be willing to say, you know what, this isn't right. Or you know what, like, can we use this language instead? And be the initiator of that and the champion of that. And the more we do that, the rest of us will see it and be more likely to do it as well.
Great, thanks. And just a reminder, if you have any additional questions, feel free to add them to the chat here. Those are the two main ones that I had coming, Gloria, but if anyone has any others that they'd like to ask now. Just typing.
Well, thanks for your time and your attention. I really appreciate it. Dylan, thanks for finding those questions for me. And I hope everybody enjoys the rest of the session.
Thank you, Gloria.
Thank you very much, Gloria and Dylan, for that presentation. That was fabulous. I would actually now like to introduce Sean Collins with Seabrook. He will be introducing our next presenter.
Hello, everybody. My name is Sean Collins. I'm an addiction recovery specialist at Seabrook. Thank you for that wonderful presentation, Gloria. That was excellent. It's my pleasure to introduce Dr. Joseph Ranieri. Dr. Ranieri is one of the staff physicians at Seabrook. He's a gentleman, he's a personal friend as well as a work colleague, and he's one of the people that have a lot of letters after his name, so I won't read his whole bio, but just a quick background. He's a staff physician at Seabrook. He also is board certified addiction medicine and family medicine. He's also past president of New Jersey chapter of American Society of Addiction Medicine, as well as associate professors of various colleges in our area. So with that, I'd like to introduce Dr. Joseph Ranieri.
Thank you. Thank you. Gloria, thank you for that presentation. I learned some things also as a physician in long-term recovery. Personally, I mean, I've always had issues, even early in my recovery, grace of God and through 12 steps of AA, that's how I've remained sober. I did have issues in the beginning, you know, saying that I'm an alcoholic. You know, I probably the first year, I didn't have any problems with it. But then as I moved along and embraced recovery and became further and further away of, you know, not drinking. So I started to, you know, say that I was a person in recovery. If you look at the 12 steps of Alcoholics Anonymous, a lot of the things are past tense. You know, we were powerless, you know, and if we're actively engaged in treatment and recovery, then, you know, and I think it's so important to change the wording and it's at a necessary time to remove that stigma, because it is still very prevalent today. So some of the stigma that has been associated with medication-assisted treatment, that was the mainstay, medications to assisted treatment. Terminology has changed. One way we're saying medications for opioid use disorder. And when we use that terminology, sometimes some of the physicians involved with that don't necessarily do not couple counseling with that form of modality. Then we have medication-assisted recovery. So there's all different terminology that's being used today. So the disclosures, I do speak for Alkermes and their speaker bureau, and I'm compensated for that. There was a modifiable risk cigarette that I went to one dinner engagement, and I feel compelled to just put that down. I wasn't paid for anything, and that's my two relevant financial interests. So I'm going to describe some of the components of medication-assisted treatment and how stigma has revolved around that. We're going to learn about MAT also, but mainly we're going to focus on, we'll try to incorporate, how things are stigmatized. One of the ways that I see a stigma is by saying, medications to like replacement therapy. So the medication is not being used to replace their addiction, but it's used to put the disease in remission, to occupy the receptor, and to help the patient move along, for cravings. Addiction is it affects the genetic makeup and the way the genes are expressed, and that's and I like to do analogies with diabetes, with emphysema, with hypertension. We don't have stigmas associated with that. But however, some patients who are chronically not doing well with their diabetes, some physicians do have a stigma with regards to their treatment. So despite strong evidence of effectiveness, there is strong, undeniable evidence that medications reduce morbidity and mortality. And they do increase treatment retention, improve well-being, and reduce barriers. And we know that in 2019, a study of 35 adults receiving medications for opioid use disorder, we know that the 3 approved medications are methadone, buprenorphine, buprenorphine naloxone, which is Suboxone, and Vivitrol, which is naltrexone. So it's national data lacking disease onset and initial treatment. So there's a gap of 4 to 7 years before people start medications for addiction, because there's still that stigma associated with it. And also a lot of it comes from professional education and inadequate training. So one of the local emergency rooms, I'm happy to share that Jefferson Health will dose patients if they show up, not being able to get to their methadone clinic. They will dose them at their emergency room. And I think that's very, very important, because what that does, if they didn't dose them, then it can cause into a major issue and occupy more problems associated with the care of that patient in the emergency room. There's other emergency rooms that will not do that. And sadly to say, they need to be educated on the benefits, of dosing patients, in particular with methadone, if they're not able to get to their clinic. And we have to work more closely as clinicians if we're involved in methadone maintenance. There's a lot of fragmented care with patients that are on medication-assisted treatment or medications for opioid use disorder. And it's important for the individual clinicians to be in contact with the entities out there, local emergency rooms and physicians, to continue to educate them. COVID-19 has taken, the main thrust of hospitals somewhat not focusing, on addiction. They've focused more on COVID-19, and rightfully so. But now we're going to start seeing, not only for opioid addiction, but for alcoholism and the ramifications that have occurred as a direct result of the past year with COVID, and how alcoholisms and the morbidity has increased and deaths have increased from both that and opioids. So Gloria really touched base on the stigmatism, and there's a strong stigma with agonist therapy. And agonist is something that, occupies the opioid receptor, is an opioid in itself. And, methadone and buprenorphine are examples. And people refer to it as substitution therapy, which is a term that I like to stay away from. So methadone is a full opioid mu receptor agonist. An agonist is something that fully stimulates the receptor. Fentanyl, and it's illicitly manufactured today. And we're not talking about the fentanyl that comes from hospitals and then is used for, surgery procedures. If someone's going to have surgery, we're not referring to that fentanyl. We're referring to illicit manufactured fentanyl. And we're not sure of the potency rate. It could be 100 times, it could be 200 times, it could be 300 times. and now it's adulterated with other drugs, that could cause sloughing of the skin and abscesses. A drug called xylazine. It's an alpha agonist and it constricts the blood vessels. We have buprenorphine. When we say buprenorphine, also referred to as buprenorphine naloxone, which is Suboxone, and buprenorphine is Subutex, is a partial mu. So it's an agonist, but partially it stimulates the opioid receptor, and it has a much greater safety profile. And then we look at naltrexone. It's not an opioid at all. It's a total antagonist. It's used for both opioid use disorder and alcohol use disorder. And we'll talk a little bit about that. So when we look at today harm reduction, and that's what we're referring to, focusing on harm reduction. We also focus on shared decision making. So we give patients the options of various treatment options, but we need to tell them, how what the rates are of it being successful and not working. And we have to give patients, proper consent too. So we know that methadone stimulates the opioid receptor, it prevents withdrawal, reduces drug craving, stabilizes patients without producing euphoria and impairment. Of course, if a patient's abusing it, you could see euphoria and impairment. And that's where the art of, addiction medicine comes into play. That's where when a patient's going to a methadone treatment facility where you need the whole staff to be part of the treatment team in order to make sure that this euphoria and impairment doesn't concern. We know that it minimizes pathologic brain responses to stress and drug use, blocks the additional opioids. We have to be very careful about the word like achieve a blocking effect, because with fentanyl today, illicit manufactured fentanyl, it is breaking through the blocking effect of being on methadone today. So we know that it decreases drug-related crime. We know it decreases illicit opioid use. And one of the most important areas, it decreases risky behaviors, increase in substance use disorder retention. And that's the most important thing. When you compare, you want retention. When you have someone that's diabetic, you want to retain them as a patient. And by retention, you could treat a patient with better options. And we know it's cost savings for both healthcare expenses for hospitals as well as a tax burden. We know that those that need, now these regarding methadone dosing, we know that these group of patients need daily dosing. One interesting thing is during COVID-19, when we relaxed the restrictions for daily dosing, even in patients that did not meet the criteria, there was not a large increase in fatal overdoses. So it's going to take probably an act of Congress to relax the restrictions for methadone dosing, but with some lobbying by treatment providers, it could be done. We know that, again, methadone's for harm reduction, those with financial restrictions, those uninsured, some patients who have severe chronic pain, it's a medicine that could be used, and those who cannot tolerate buprenorphine. One of the big issues now we're saying is because fentanyl has a duration of, it's called the volume of distribution, of lasting about 3 days. If you are to give a medication like buprenorphine, you're going to precipitate withdrawal. Because remember, buprenorphine is a partial agonist and fentanyl is a full agonist, and you could get precipitated withdrawal. And a lot of patients know today that it takes 2 to 3 days before they could start using any type of buprenorphine product for medication-assisted treatment. And it's very difficult for patients with addiction to achieve 2 to 3 days of abstinence. So methadone is a smooth transition. You don't need to wait 2 to 3 days. You could dose them that day if they used the evening before, and they're not impaired when you see them. You could go right into dosing them. And we know it's a first-line preference in patients with pregnancy. So some of the problems with methadone, and we just have to be cognizant of it and mitigate these risks. We have to worry about life-threatening arrhythmias when you get into higher doses. There are some, 300 medications that can cause what they say is QT prolongation. Of those 300 cases that occur, a year, there's 300,000 patients that can develop QTc prolongation or torsades, and maybe only 15,000 patients actually die from torsades, which is a lethal arrhythmia. Or we have, easy 100,000 patients dying from opioid overdose. There may be significant drug-drug interactions, so we have to make sure what the patient's on and risk mitigate with regards to that. This is a big area of concern. Is we know that patients that have addictions will be using CNS depressants like sedatives, benzodiazepines, both illicit and being prescribed. And that's a challenge in mitigating that risk today. We know that patients that have a risk of seizures, we need to monitor them with regards to being on methadone and may need to get a cardiogram if necessary. Again, one of the issues is third-party risks. If somebody's on methadone, and making sure that they're not impaired while on the medication, that if they leave the clinic and they're abusing, say, CNS depressants, that they don't harm themselves or someone else. It can also cause low testosterone with regards to sex drive. Sometimes it can lower pressure too much. And if it's mixed with antidepressants, and there could be something called serotonin syndrome. So this is the concept of deciding when a patient when a patient needs daily dosing or they can have take-home bottles. Again, the guidelines are very stringent. COVID-19, we had the ability to relax it, where some patients were getting 6 take-homes during a week when they really should have been getting dosed daily. Patients with comorbid issues like emphysema, older in age, we gave them 14 take-homes when they might have been only able to get 2 take-homes on a weekend. We have to be assured that the patients store their medication and there's accountability, absence of criminal activity. If they have regular attendance, they're not missing doses on a regular basis. We're trying to make sure that they have an absence of serious behavioral issues at our clinics and assess the risks versus benefits of retention. We don't want to, administratively withdraw patients that are on methadone because we know that the outcome is going to be far, far worse. So I like to keep that vocabulary, I don't like to even mention it if at all possible. And we know with a recent study from the state of Connecticut and what we saw in the state of New Jersey, that there was not an increase in fatal overdoses by giving patients more take-home doses. With buprenorphine, Suboxone, it's much more relaxed. Usually, if a patient comes in, buprenorphine is again a partial agonist. It's got it's what they call as a ceiling effect, meaning at doses you won't see the overdose deaths that methadone can cause. So it's a very safe medication, and it's why we use it so much. But the problem is getting patients to go on it on an outpatient basis with the advent of fentanyl. Every patient that's using heroin is fentanyl's in it, and it's difficult if a patient goes to an outpatient office to start MAT with buprenorphine. You have to give them at least 2 to 3 days worth of comfort meds, like clonidine, which is a comfort med, maybe something like a muscle relaxer or something for sleep, because they're going through intense withdrawal. And in and of themselves, those non-opioid comfort medications may not be effective. So what we're starting to see is increased relapse rates and an inability to move that patient into an induction on an outpatient basis. So we're starting to recommend going inpatient for at least a week to get started with an induction. We know that Suboxone maintenance or buprenorphine naloxone can be implemented in a primary care. There could be home inductions. And I feel that there should always be some form of of counseling or 12-step recovery, or meet the patient where they're at. They may have another path to recovery, and we need to be open to that. And patients need to be on it, need to be on it lifelong if necessary. It was approved in 2002. And I'm starting to see that patients, the most widely utilized dose was 16 milligrams. However, with the advent of fentanyl, now I'm starting to see that patients may need up to 24 milligrams a day. We used to say it could block or attenuate additional opioids, but with the advent, and we're talking about morphine here, but with the advent of fentanyl, I am seeing patients, the fentanyl breaking through the blocking effect of buprenorphine, and it's breaking through the blocking effect of methadone too. Again, it's a very favorable safety profile. If myself, that's opioid naive, if I was to take 6, 7 buprenorphine, I wouldn't have an overdose. I would become euphoric, but I wouldn't overdose from it. And we used to say at equal efficacy to 60 to 80 milligrams of methadone for abstinence, treatment, and retention, everything has doubled. So if 60 to 80 milligram were average doses of methadone used for abstinence, for treatment retention, for craving reduction, now we're seeing double that amount, if not more. So everything is changing with illicit manufactured fentanyl. So we have diversion mitigation strategies. That's why we have methadone treatment centers. And the methadone treatment centers also prescribe buprenorphine naloxone. We have outpatient treatment centers when we see that maybe those patients have less diversion and higher accountability with family members or themselves. And OBOT, it's referred to as OBOT. And when we see a patient have meaningful recovery, meaning favorable urines, they've reversed their social impairments, maybe they've been involved in counseling, maybe they've not, then we can consider and talk about tapering. But tapering has to be done over many, many months. It could take 6 months, 12 months, or longer, a year and a half. And it could be stopped at any point. It could be reinitiated at higher doses if necessary. And this is a chronic disease, and we have to treat it long term. And we're still doing these short-term quick fixes, and they're not working. We have to look into long-term housing for patients that are having problem with opioid use disorder, as an example. So we have to, we're increasing access to treatment, office-based OBOT. It's a partial agonist. Again, blocking effects, with illicit manufactured fentanyl. Illicit manufactured fentanyl is in Percocet. So if someone say, well, I'm using Percocets, they can't be guaranteed they're getting Percocet from a drugstore. The Percocets that we're seeing out in the field today are illicitly manufactured, and they have fentanyl in them. So we're seeing it in Xanax. Sometimes we're seeing it sprayed on cannabis. You think you're getting stimulants, methamphetamine that has, it's all pure methamphetamine, and it could be adulterated with fentanyl. So this is an example of a Yale study that was done in 2015, which linked a treatment to referring, not just giving a patient a handout. That doesn't work anymore, a handout. We need the link treatment. Thank God for the navigation nurses. Thank God for recovery coaches in hospitals. And now we're linking care. And thank God for hospitals now involved with treating patients for addiction. I think the next phase would be to get hospitals to dose patients in their emergency rooms, with methadone. Now, New Jersey paramedics, this law is going to get codified and into law where they're allowed to administer buprenorphine after a overdose reversal. They're doing it now. There's a pilot program going on at Cooper. So one of the problems with buprenorphine is it can precipitate withdrawal. That's why I see more and more patients, gravitating towards methadone maintenance and methadone. Now there could be you could on an outpatient basis do what they call as microdosing, but it takes a very motivated patient. So microdosing, where we used to say when heroin was prevalent, well, you need to wait 12 to 24 hours, and you could start by taking 2 milligrams, 4 milligrams, or 8 milligrams of buprenorphine. We know today if we do that, there's going to be major precipitated withdrawal. So some treatment centers at Cooper Addiction Medicine have been doing microdosing where they start with 0.5 milligrams or less. They might start it off with once or twice a day and gradually move up and offer some comfort meds, and have been able to start an induction using that strategy. We know naltrexone is becoming even a greater challenge today. One of the best areas to start naltrexone would be for alcoholism in particular. I know we're talking about opioid use disorder, but alcoholism is a medication where you could start, the day that you see the patient on it. For opioid use disorder, the problem is you have to wait at least 10 days before you could start naltrexone. So if a patient comes into treatment in an inpatient setting, most likely they're not going to even be able to be started on tapering doses of buprenorphine naloxone for withdrawal management until about day 2 or 3. So the first 24, 48 hours, maybe 72 hours in this inpatient setting, they're going to have to get comfort meds like clonidine, muscle relaxers, antihistamines. Some treatment centers are using Librium and lorazepam, the first, which is Ativan, benzodiazepines. Some are using phenobarbital, which is a sedative, for that anxiety component of the withdrawal for the first 2 to 3 days. Then they're starting the buprenorphine taper, maybe 8 milligrams twice a day for the first day, and then they go 6 milligrams BID for a few days, 4 twice a day for a few days, and then daily. That's about 7 days. So by the time you're able to start the induction with naltrexone, it's going to take another 10 days. So we're talking about at least 15 days inpatient. Try to achieve this on an outpatient basis. The success rates are very low unless a patient has received this induction dose of naltrexone inpatient first. So the cautions with naltrexone is if a person has an allergy towards it, and that's a caution for all drugs. You could have an anaphylactic reaction with methadone, with buprenorphine, and with naltrexone. It's very low. We know that we have to avoid this in pregnancy, even though they're all category C pregnancies, which means in animal studies, they've shown the possibility to have adverse effects. We know that methadone is the most widely studied and the drug of choice. Buprenorphine could be used if a patient chooses that. But right now, the American College of Obstetricians and Gynecology have not advocated the use of Vivitrol. Some with informed consent, if you're already on naltrexone and you become pregnant, if you're told about the risks, some patients may opt to want to stay on it. And we know that with naltrexone, if somebody starts off with severe liver disease, we just need to wait until maybe their liver enzymes come down, and it may take a week, before that, especially with alcoholism, before it can occur. With opioid addiction, we normally don't see these issues with elevated liver function tests. And we know that naltrexone can precipitate withdrawal at a greater extent than buprenorphine. So we have a requirement for what we call is detoxification, the old terminology. Now I like to say withdrawal management, because when we say the word detoxification, we refer to detoxification to complete abstinence. And there's a very small percentage of patients that remain complete abstinent. Some studies have shown, after a detox in a treatment center, the relapse rates, can go up to 75%. You may only get 25% that remain abstinent, but we still have to do shared decision making and talk about, these different options for patients. Naloxone is very, very important to issue naloxone for every patient that has opioid use disorder, and it's still not being done. and that's just an unbelief on my part that that's not occurring. So if you're part of a treatment event, and even if you're not the medical portion, please make sure that your providers, the nurses there, the clinicians, the APNs, the PAs, the physicians, are constantly asking patients and yourself whether they have naloxone at home, and make sure it's in date. And if they don't have it, they need some, get your medical providers to initiate a script. In the states of Pennsylvania and New Jersey, the pharmacists can initiate naloxone without a prescription. So personally, I still feel that there needs to be some cognitive behavioral therapy with medication for opioid use disorder. There's contingency management, there's peer support, there's 12-step recovery, there's Christian-based programs, there's family treatment. Family treatment is so important for them to understand the disease of addiction, mindfulness, guided imagery, smart recovery. There's Medication-Assisted Recovery Anonymous for those that are on MAT, medication-assisted treatment, where they feel that they're being ostracized or they're stigmatized by going to a 12-step recovery meeting and stating that they're on medications for assisted recovery. They're not as prevalent, as the abstinence-based programs. So the ultimate goal is to initiate long-term recovery, maintained with or without medications, through shared decision-making. We have to be very careful when we say without medications. We have to make sure that we've fully informed the patient of the ramifications of not going on a medication to assist in their recovery and what the consequences could be. And we have to realize that there's going to be improvement in physical, emotional, psychological, and I still feel personally spiritual aspect of one's life. The current data highly favors medications to assist medications for opioid use disorder. There is emerging data on naltrexone where it could be initiated through some form of microdosing, but that's something that needs to really probably be done in an inpatient setting. When we looked at the CDC guidelines for prescribing opioids, the majority of the categories and the evidence was less than A, might have been C. It was a lower type evidence, but the one area where it was a category A and evidence type 2 is medication-assisted treatment. And this was back in 2016. And it has more emerging data today that it's highly underutilized. And, and I think it comes from a major stigma associated with its use. So again, we have to look at the short-term treatment is not recommended for chronic diseases, especially opioid use disorder, alcoholism. We have to look at the reduced consequences. We may not eliminate harm, but if we can reduce it, then we have moved in a direction where we can help patients. We can help extinguish, in some instances, the new, we need to make new neural pathways, but that's through repetition. That's through where we need some form of recovery modalities, on a daily basis. So our goal is minimization of harms from ongoing usage, reduction or cessation of opioid use disorder symptoms, protect against overdose and death by suggesting MAT, MOUD, MAR, teach the necessary goals for craving and less stressors without abusing drugs. And that's what I'm trying to get our therapists to provide more of, and not throw our hands up, and say, oh, we need to go up in the dose of the methadone. We need to go up in the dose of the buprenorphine naloxone. Let's try other strategies too, in reducing, abuse. So the traditional drug-free approach has high failure rates, especially, with the advent of fentanyl. We know that detoxification without MAT leads to that high failure rates, as much as 75%, or less than 75% are abstinent in 1 month in one study. So we've identified environmental cues and triggers, stress management. So we have to go beyond the medications also for patients into dealing, with opioid use disorder. We got creating recovery networks are so important. Regulating our negative emotions. Now, I'm always constantly trying to, talk to patients about this, not only about increasing their dose, but, to have positive affirmations, to use the words that are less stigmatizing, that they could say. And I ask them, how they feel about that and what their opinions are about it. So I want to thank everyone for having the opportunity for me to be on this program today. And if there's any questions, I'm open to discussing them.
Thank you, Dr. Ranieri. We actually have a few questions that people asked during your presentation. One of Dorothy had mentioned, and Dorothy, you might be able to expand on this, but Dorothy asked to hear more about fentanyl. Dorothy's OFR team has debated the fatal level. One member insists that 2 mcg of fentanyl is considered fatal, but online searches say 2 milligram. What do first responders need to know? Fentanyl is so prevalent, and they are likely persons providing Narcan.
Right. So everybody has different tolerance levels. So fentanyl in itself, its potency, again, and illicit manufactured fentanyl, we don't know the potency of it. We don't really have any human studies on assessing the potency. A lot of the potency studies were based on animal models, and we just don't have that information. We know by what we're hearing from the field, where some patients will need, where 2 milligrams of naloxone, which was the normal dose that we used years ago with fentanyl, may have succeeded in reversing an overdose. Some patients need to get, 6 milligrams, 8 milligrams, 12 milligrams of naloxone to reverse an opioid overdose, because if it's illicitly manufactured. It's illicitly manufactured, and what they're doing is they're coming up with what we call as different analogs. And what that does is it changes the potency. And there's a lot of questions we don't know about it, but we know that there's much higher fatal overdoses over the years. I think this year we've had data like up to 90,000, 95,000 reported fatal overdoses with drugs, and 3/4 were probably related to fentanyl. And that's probably underreported. So it's important to have as much naloxone in the house, or as possible, to help reverse an overdose. And never to give up. Never to give up. I mean, I've had patients where they might have had multiple overdoses and have finally attained meaningful recovery, while on methadone, buprenorphine, or Vivitrol.
Dr. Neary, there was another question, and we had quite a few, so I'm just going to lump them all together since they all around the same issues. There are questions about treatment centers, people in recovery support groups, family members, employers or unions who feel that utilizing MAT are not in recovery. How would you respond to that?
No, it's I brought it up to my treatment team yesterday, where we were talking about 2 or 3 of the local hospitals in Pennsylvania that seem to have a high stigma with patients that show up at their emergency rooms for medical problems associated with their addiction. And I've decided that I need to do a in-person visit and talk to, start with the ER director. And I'm not I'm not, I may have to, and I feel at times where, in order to reduce the stigma associated with addiction, that I talk about my own recovery, that I'm a physician in long-term recovery, and that I've been blessed and not to have that stigma associated at most part. I did experience it once or twice on occasion, but I looked at it at that person needed to be educated. So that's what it's all about. It's education, it's discussion. We have to break that wall down that still exists. From 2012, and Sean, you could share how, when I was the medical director at Seabrook, how I did a lot of continuing medical education units to physicians, to ER physicians, to physicians, osteopathic physicians, allopathic, MD physicians, therapists, and how over the years we broke down that wall that was associated with the stigma, and how we got primary care doctors to start referring patients for treatment. So we still have a lot of work to do, but Sean, you could comment on, even then we started to see ER physicians, a handful, started to offer buprenorphine in their ER. And now I'm seeing, a couple hospitals offer methadone. Now, not starting the maintenance, but if someone should miss their dose that day, they're offering it. But we still have a lot of work. Probably what we're seeing is a small percentage, I don't know, 15, 20% of physicians, clinicians, offering the medication, removing the stigma associated with addiction. But we have to increase those numbers, reduce that stigma, and we still have a lot of work to do.
That is correct. You and I have been through a lot during the years, Dr. Ranieri. And when we first started this, you're right. A lot of, let's say, primary care physicians and so on, they one of their patients presented that they had an issue, or the doctor identified that there was an issue, and they immediately said, well, I don't know how to treat that. And they send off to, they give them a piece of paper with a bunch of phone numbers, say, call here, see if you can get the help you need. But we have seen a lot of providers become ex-waivered, and I know you and through the Centers of Excellence in New Jersey, as well as many other wonderful organizations, have helped many providers become ex-waivered to administer buprenorphine. So,
and one of the greatest growth areas I've seen, Sean, is hospitals. At one time, hospitals did not treat addiction very well. And now we're seeing hospitals do an excellent job. COVID set things back, I'll have to say, but I think the hospitals are going to move in a positive direction forward, and we're going to see more hospitals get back into treating addiction and treating it correctly. But we still have a lot of work to do.
I think you answered all the questions, Dr. Ranieri.
Okay, thank you.
Anybody else on here have any more questions for Dr. Ranieri? All right.
All right.
Laurie, all you.
Thank you very much, Sean, and thank you, Dr. Ranieri. That information was excellent. I would like to now introduce Jennifer Peelhow. She's the Director of Substance Abuse Services for the county, and she will introduce our final speaker for the day. Thank you.
Thanks, Laurie. Hi, everyone. Yeah, my name is Jennifer Peelhow. I am the new Substance Abuse Services Director here at Atlantic County, and I have the honor of introducing a very passionate individual that many of you probably already know. Chris has been in the field for over 18 years. He started his experience at Lighthouse Treatment Facility as an adolescent and adult intensive outpatient counselor. He also did some counseling for Harvest Counseling Services as well as Serenity House. And a little more recently, he became the founder and CEO of Hope All Day Foundation Recovery Center and joined Rutgers as a peer specialist health navigator. So I'd like to turn it over now to Chris Maycomer, and welcome, Chris, and thank you for joining us.
Thanks, Jen. Can you hear me? All right, good. So my name is Christopher McCumber, and I am a person in long-term recovery. And what that means is I haven't had a minor mood altering substance since 5501. I haven't found it necessary to take a drink or a drug. My life is completely different than it was prior to getting clean. But I heard a lot of good information just sitting and listening. And, I, as Jen mentioned, I do have some experience with inpatient counseling and outpatient counseling. And, I don't really think that when I got clean, I ever really envisioned this as my pathway or my lifestyle. But I've heard when I got clean, you want to make God laugh, make plans, So, I had in my own personal 12-step modality that I attend, I had this H&I commitment, and I was going to the Lighthouse, and it was a hospitals and institutions commitment. And I would go into the Lighthouse for the adolescent side. And, something happened there. The people there saw something in me at the time I didn't see in myself. And, one day somebody said something to me, hey, would you like a job? And it was like the farthest thing from my mind. And who knew that I would be good at it, And so that's kind of where that took off. But I want to back up a little bit and talk little bit about, because we're talking about addiction and the stigma in treatment and the harm reduction stigma and a lot of that stuff. And that plays a big part into segueing into where I'm at and what's taking place. And, and me being now in my 21st year of recovery and a proud 12-step member where I go. And, I also go someplace on Sunday to enhance my spiritual conditioning. But that's not where this all started, and I want to just kind of take a little trip in the Wayback Machine and talk a little bit about, we do treatment and one of the things that I've noticed over the years, how, we treat addiction so much differently than we treat other illnesses. We have this acute care model with addiction where, we diagnose, we detox, we treat, we educate, we discharge, and we sever the service relationship. And that all takes place in 21 days or less, and then we do a discharge plan and off to the street you go. And then it's like, just imagine this for a second. Just imagine you're driving in your car and, you see this guy on the side of the road, obviously homeless, panhandling, it's 90 degrees out. You got your air conditioner on, and you're nice and cool in your car. And you see this guy and he visibly distraught, visible track marks because it's 90 degrees out, you can see. And, the thought is, oh my God, this guy's panhandling for drug money, So my question is, what does the next 10 years of his life look like? Where does that person end up? Does he end up in prison? Does he end up in multiple detoxes? Does he end up in multiple county jail stints? Does he overdose and die? Where does that person end up at? And the stigma around addiction and recovery, we're 100 years behind the 8 ball. I mean, we've come a long way, but if you think about it, addiction has been criminalized. It's been considered, it was viewed as a crime for over 100 years. If you were an addict or an alcoholic, it was a crime to be one of those things, and we've come, like I said, very far out of the shadows. But, even myself, I'm prone to judgment on what I see, and not because we can't see behind the curtain. We don't know what happens. And so this guy that's panhandling for whatever, for drug money or whatever, where does he end up? Jail, blah blah blah. What's the situation? You know, does he end up in prison with no driver's license, no family support, 20 some arrests, maybe, 8.5 years incarcerated in the New Jersey prison system, 3 felony convictions. And, now in our society, we sensationalize, media sensationalizes addiction through rap culture, music culture, TV culture, movie culture. There's always some type of hidden stigma or innuendo about addiction and what everybody's perception is of people that do that, or that are, struggling with a substance use disorder, and then, so my question is like, we're at this crossroad now where we got this guy that's multiple attempts to stay clean and recover, and here he is standing at the gates of a prison, right? What are his options with multiple arrests? Like, what are his options for long-term sustainable recovery at this time? Let's just say he's 30 years old. What are his options? No driver's license. So the stigma of addiction is one thing, but to have a criminal record is a whole nother piece of the stigma that takes place. It's one thing to be struggle with a substance use disorder or a drinking disorder or whatever, and never be incarcerated, never have a brush with the law. So you may struggle with the idea that you're an addict or an alcoholic, but you could still go get a job, so you could walk into a place and you don't have to check a box that says that you're a convicted felon. And so this guy, what does he do? Where does he go? He's already starting at less than 0, and it takes, it's one thing to make it through the detox stuff and the education and the treatment and, get to a place where you can, physically yourself walk into maybe a 12-step meeting or a church meeting or something of that nature. But like, then what? Then what? Until we can get the support of, other our society in general has, basically stifled, for example, our RCO is we're not for years we weren't funded by anybody. A lot of these grassroots are organizations, and I'll talk a little bit about that. But until we get the support and change that view, that public perception, that won't change. So I want to talk a little and talk a little bit about what's happening now, and that struggle that I was talking about is so dear to me, because that was me. That guy was me. So when I came home, there was not a lot to offer for me. I remember going on the boardwalk in Ocean City. I lived in a recovery house on Central Avenue, and a lot of the place, I got all these applications in 2001. We were still filling out paper applications, and I would bring them back up and wait for a phone call at the Oxford House to see if I got a job. And after 27, applications and, 27 no calls, and, and then I talked to my sponsor, and he's like, well, go back and ask him, only to go back, with my tail between my legs and ask these people, did they look at my resume? And then for them to turn around and say, no, because you have a criminal record. So I remember telling my sponsor that, and he said, well, Chris, what are you good at? And, I'm always good with my hands. I'm very, artistic and creative, and, I'm innovative and things like that. So I'm good at construction. And he said, well, you might have to make a job, So with my own personal, recovery, modality, I was kind of trying to figure out where I was going to fit in life and how was I going to sustain this thing and not go back, you know, because every environment that I ever came from was the abstinence hostile environment. Like it wasn't okay to be abstinent where I lived. It wasn't okay to be abstinent in the family that I came from, let alone go to any 12-step modality, because there was still a shame to that and a stigma to that. You know, I mean, even you can't say, if somebody says, well, here, have a drink. Why don't you drink? Oh, I don't drink. I go to AA. You know, there's even in recovery, there's still that shame and stigma and the judgmental perception that, oh, you're a failure in life because you can't handle your alcohol, or you're a dirty junkie because you shoot heroin with puddle water, you know? And so every atmosphere that I could have went home to was, you know, a hostile environment, family, friends, the corner where I grew up, my old house. So, you know, for me, making that conscious decision, you know, through some advice from the clinical team not to go back to that environment was probably one of the best decisions that I had ever made. You know, and then life takes off, you know, but I want to talk a little bit about, you know, how do we continue to overcome this stigma in recovery? Because a lot of us get clean, stay clean. You know, now all of a sudden we join life, and you know, it's you know, it's real to be. It's good to be clean. Life becomes fun. It becomes real. You know, and then you wake up one day and there's all these responsibilities, and you know, you're like, all of a sudden now you're like paying bills, and you know, it's getting a little bit mundane, so how do I continue to engage in that, you know? And you know, this is where for me, I kind of got the you know, a little spiritual nudge, I'll say, while I was working in treatment, doing a lot of discharge plans, and then seeing the recidivism, and it was happening with a lot of younger adults, and you know, they were going out to recovery environments and coming right back to us, and there was no continuum of care. There was no warm handoff. There was nothing else. You know, now don't get me wrong. You know, 12-step modalities have been working since 1937. And there's over 23 million Americans in long-term sustainable recovery because of it. So I know it works, but we're in a different time now. Things are different. Drugs are different. Treatment's different. You know, there's a lot of things that are taking place now that's very different than it was 20 years ago and 30 years ago, and so on and so forth. So, you know, I started doing these recovery houses, and I was helping guys, and you know, I was giving them jobs, and I noticed one thing, that if I could hand walk these guys from treatment to a sober living house, and then meet them at the house and give them a job and pick them up in my truck, and then after work, take them to a recovery event or a recovery meeting, and then drop them back off. And the more I engaged that process with those guys, the better success I was getting with these guys personally. And, you know, and then so, you know, God just moved me in a different direction. I had taken a trip down to Florida, and I saw something down there that I really didn't experience here in Jersey. They had some real big recovery clubhouses, and you know, there was a lot of engagement there. And one of the things that really struck me was that they were open, you know, all day, every day. And that for me was the light bulb, you know, and that was 2005. And I had about 5 or 6 years clean at the beginning of 2006. And, you know, something happened when I was down there. I just decided that I was going to stay there and go around and look at all these other places. So I did. I stayed there, and I went to all these different recovery environments, all these different clubhouses, and checked out all these places. And, learned a little bit about how they started and, all this stuff. And all the while in the back of my head, I'm like, man, someday, we got to have something like that in Atlantic County in New Jersey. And at the time I was living in Ocean City. I had my business in Ocean City. I was working from treatment in Ocean City. And, things were good. My life was good. I met a woman. I got married. I moved. And, my wife is also a person in long-term recovery with 17 years of continuous recovery. And she's a therapist at Ancor for the criminally insane. So she understands what we're all going through. As it's a great, we make a great team. So she understood my passion. But I believed that everybody wanted to help like I wanted to help, and I tell you, even with 10, 11, 12 years clean, I ended up making a decision. I had some guys in a recovery house one day, and this was the catalyst. A couple of them had gone out and used. And at this point in time, to be honest with you, I was not surprised by these younger guys going out and using. I was more surprised by the guys that stayed, because this message that relapse is a part of recovery was like ringing, and it really was resonating very wrongly with me, because relapse has nothing to do with recovery, and it really bothered me. So, I mean, is it part of treatment? It can be, but I'm talking about recovery. So these 3 kids ended up using in this house, and so the house called me. I go down there and I call their parents. They had to go, and one of the moms put them in a hotel down the road. So I go down there, and the next morning she calls me and she says, I want to take my son to one of them classes. And I said, what are you talking about? And she's like, them classes they go to at night. And I said, oh, you're talking about a meeting? And she said, yeah. I said, oh, well, it's 6 o'clock in the morning. And she's like, so you're telling me there's no hope for my son until tonight? And I was like, man, I mean, it hit me like a lightning bolt, and I left that encounter with her and I said, man, there needs to be a place where there's hope all day, like every day, in between meetings. Because the next question that, I've been asking for years is, where does a 19-year-old IV heroin addict go for fun after 12-step meetings, in between 12-step meetings, in between IOP, after IOP? What do they do for fun? Because the normal pleasure sensors, what they used to do when they're in active addiction, is hijacked. So what are they going to do now to stimulate that and have fun in recovery? And, so I proceeded to start this thing, and I had no idea really what was going to happen or how it was going to work. I know I worked hard in my life, and me and my wife saved a lot of money, and we were doing really well, and we were going to buy a house after we got married, and something happened, and me and my wife, we sat down, we made a decision, and we decided that we wanted to do this foundation thing, and we wanted to see if we could actually, I wanted to see if the community was as open and as willing, not only the public community, but the recovering treatment industry and all these other, if they were really going to put their money where their mouth was and say that they really wanted to support this idea, and so I started this nonprofit, and we got a lawyer and accountant and did all this stuff, and 9 months later we had a 501c3, and I had recruited some people in recovery that I had developed relationships with for years, and some things came around. We ended up getting a building through another person in recovery, and what took place there was nothing short of a miracle. In 2014, we opened our first peer recovery community center, and the business plan was so ironic. We did the grand opening, and the next day I went online and I was looking at some stuff, and I seen this thing pop up from the Recover Project from 2008, and there was a whole thing on RCOs, from Rutgers University on how to start a RCO. And I'm like, man, I wish I would have seen that last year, you know. But it's so it was so eerily similar to what we had decided that we wanted it to look like. And, you know, what we wanted it to look like was that after treatment, come here. So now so you need a job, you know, you need a safe environment. So the idea of recovery community organizations, you know, even work recovery community organizations, like employers that are, you know, susceptible and agreeable to people in recovery being hired. You know, there was a lot of different obstacles that we had to go through. NIMBY, not in my backyard, the whole thing, you know, and everybody's like, oh, what are you going to do? What are you? What is it? And I think there was like a big lack of education around all that, because anytime you say the word clubhouse, people think of bikers and meth, you know, and it's not, it doesn't go over well, you know, and it really started to take off. And, you know, we ended up with about close to 1,000 or so walk-ins weekly. And I think that probably 600 of those were non-duplicate, or no, 400 were non-duplicate and 600 were duplicate. But we had a bunch of 12-step modality meetings. And the Cape Atlantic area, Alcoholics Anonymous, Narcotics Anonymous, other agencies, and NCAD, YPR, and like all these other grassroots organizations started evolving at this place from that environment. And what we started to see was that it was holding up the recovering community long enough when they left treatment, long enough to stay and grab onto something, you know, because listen, I'm not an educated person. I didn't get educated. I built this on passion and purpose. I didn't go to school for this. You know, I was at over 50 funerals in 2012, and I was just mortified. You know, friends I grew up with and their parents, and you know, it was a catastrophe. I was burying my friends' kids. I was burying my friends, and you know, to see that now, you know, I remember last year we had continued to write some grants, and I want to tell you, you know, I got to be completely transparent. There not only was there some stigma in the community, but there was also, and I don't know if it was considered stigma, I would say doubt, because we had written 3 or 4 different grants to Sampson Division of Addiction Services, and we were denied any of those funds because of fiscal viability, and we weren't attached to a licensure. So even though we were doing this already and not writing a grant in the third person and saying we might do this stuff, we might have this is what we're planning, and here's our projections, and this is what could happen, and this is what we had the outcomes. We were doing it, and they still were like, I don't know, you're just a bunch of addicts doing this thing, and you know, congratulations, keep it moving. And we got denied like 5 times through SAMHSA. You know, but we persevered, we continued to go on, and only because I believe in this. And I tell you, one simple thing made me, because I kind of bowed out. I did, Jen alluded to it. I sold my construction company, and you know, when I turned 50, I was like, all right, this is it. I'm just gonna, somebody gave me a link to a job that I just never really considered. At Rutgers University as a University Behavioral Health, as a behavioral health navigator in the prison. And so that's what I do now. I've been doing that probably 2019 or so. And, you know, it's a great gig. I love it, but I gave up. I was like, kind of, you know, we still had our 501c3, and, you know, we were just doing services over the phone and doing sober living outreaches, and, you know, toiletry outreaches, clothing outreaches, ride outreaches. Me and Sherry were doing all this stuff, and other people in the organization still helping people. And, you know, the mountain to climb to get another facility, and the cost, you know, I mean, I accrued a lot of cost personally. Chris McCumber did, And to be quite frank, I would do it again. If I had the money, I would do it again for one simple reason. We had a 4-panel board of directors, a 10-panel steering committee, 46 volunteers. And when we did our grant this time around for the initiative grant, we took the numbers. Out of that 46 volunteers, 32 of those 46 were still clean, and like 20 some people still work in treatment out of those people that volunteered at the recovery center. You know, and I'm paraphrasing, the numbers could be a little different, but just that alone, you know, allowed me to believe, like people like Susan Long, Ashley Francesco, Anna Mullins, you know, Scotty Grass, all these people that I know that are in the field that are doing what we do now. All those people started there at the recovery center. I mean, Susan Long came 90 pounds. She was sitting behind the cafe, volunteering at the cafe. And she said, Chris, what do I do now? I said, come back tomorrow. And she came back the next day and she's like, Chris, what do I do now? I'm like, come back tomorrow. And she was volunteering, helping, serving coffee, and like the shyest, timidest little thing. And she says, the next day, she goes, Chris, I'm back. And I'm like, yeah. She's like, I said, what do you want to do, Susan? She's like, I want to get my CADC. I said, well, you're worth more than a certification. Go get a degree. And she went to school and got a bachelor's degree. Then she got a LC, and she got a master's degree. You know, so now she's running Hope One. Those handful of incidents, 10, 20 people that I know that have found sustainable long-term recovery from the peer continuum of care model, this peer-to-peer, we help you, you help us, come back, help some more people. And it's all comes from the you can't keep it unless you give it away type of thing from 12 steps, but it's all day, you know? So we did reopen last week, 2 weeks ago at the new place, and we did receive some funding through a lot of, you know, perseverance and prayer. And, you know, I will say that I think that the tide is turning. I think that there is more open-mindedness now towards the peer movement with recovery coaching, CPRSs, and all that stuff. I think there's a value there if to long-term sustainable recovery. My idea is to create an atmosphere, an RCO, right, which we have, that, you know, when in the 80s, when I was a kid, there was this movement, the straight edge kids that skated, right? And they were like skate or die kids that didn't smoke and didn't drink, right? And they were like this straight edge. So it became like this movement in the 80s, and it was very popular. And they did magazine articles on it, and, you know, and then all of a sudden it just fizzled out because there was nothing sustainable behind it. It didn't have anything, no foundation. It was a small idea with a bunch of skater people that went across country and back, and then it fizzled out. But now, if we can, as everybody, all inclusive, from detox from doctors to emergency rooms to hospitals to treatment centers, if we can all get together and all be on this and have the same idea that after the education and the medical part is done, and even while the medical part is happening, if we can provide it's not enough just to have the willingness to recover. We need to provide a world that they can recover in. If that's not available to them, they're going to keep going back out. I'm watching it happen right now, every day of my life. I mean, I work, I have a house, I have a home, I have a job, I have a dog, I have hobbies. But one thing I still do is I still maintain my own personal recovery. So I'm still on the front line. I'm still in the trenches. I still have a home group. I still have a sponsor because I want to stay connected to exactly where the pool of people that need to be in recovery are. You know, so if we can create an environment that will hold that up and sustain that, these younger kids will find a passion and a purpose. And then 10 years from now, they'll be on this call and I'll be somewhere in Florida, hopefully. You know, that's the idea, you know. So I don't know if I talked any about any of the stigma involving all that stuff, but I just know that we're heading for some stuff with the crystal meth that's going to blow the socks off of, and this fentanyl off of the Oxycontin and opioid epidemic that we went through already, and that we're coming out of. Far greater a need is going to be coming down the road. And addiction and alcoholism is a disease of isolation in and of itself without COVID, and we just went through a year of isolation and separation on top of isolation and separation. So the depression and the anxiety and all the stuff that's going to unfold from that, community peer centers where families can get together and be educated about addiction and recovery. And listen, and families can be educated on how they can recover, not just, to learn about why their son or daughter is the way they are. We've been asking why for far too long. We need to ask how did it happen? Not why don't you stop? Why can't you just stop? No, like, how did it happen is really more important than anything. So parents, grandparents becoming parents again, it's like, it's so prevalent right now. Every one of my friends that I grew up with, predominantly, there's probably about 10 or 15 core guys and women in Mays Landing I went to school with. Most of their kids are in trouble in one way or another. Some of them I got into treatment, and they wonder how it happened. That they're still on the same bar stool. Some are, some ain't. But at the end of the day, I think to myself, what's going to be the catalyst? I think about, like, if we can make recovery a genre, like, I know AA and NA very popular and all that stuff, but a complete separate entity outside of those, with the support of those, that is self-sustainable through other services that would make people come and engage in the recovery process and make it become a way of life, and not just a 20-day stint when your insurance is going to cover it, or if your Medicare, Medicaid, or whatever it is going to cover it, and the education is just the beginning. The recidivism, I'm not going to get into that, because I know that recovery works. I know that the recovery is possible. I went from DOC to CEO back to DOC. So if a guy like me, that I told you was panhandling and shooting toilet bowl water out in Mays Landing, can open a recovery community center in the same town 20 years later, anything's possible. Anything's attainable. I bought a home, and all the stuff that we talk about that seems like normal things for normal people. But for addicts that are struggling with the hopeless dilemma that they're in, it's just the magnitude of the miracle is staggering. So I don't want to run too long. Thank you, Jennifer. Thanks everybody for listening, and come out to 701 Route 50, Hope All Day Recovery Center. Come on out, come have some coffee with me. I'll give you a tour. I didn't do a PowerPoint because I don't want you to see it. I want you to come and experience it.
Thank you, Chris. Thank you so much. You kind of answered a lot of the questions that I had kind of in mind to ask you, but I do appreciate you sharing the story and how this all kind of came about. I think it's very important for us to hear that. Just real briefly, because we are running out of time, but do you want to share just some of the activities that Hope All Day is, doing in maybe in the next couple weeks, couple months that might be of interest to people?
Okay, so we do have a family education, Hope Family Recovery Group, Monday nights, 6:30 to 8 o'clock. Mike Jamont is running that, who's got over 20 plus years of family dynamics and family roles in addiction and recovery. We also have Andy's Glow Foundation does a grief and loss support group on Thursday nights. I think it's at 6:30, if I'm not mistaken, but you can check it out on the calendar at hopeallday.org. But we also doing a cafe night We're going to have some open mics, some poetry readings, things like that. We want these guys to get creative. We have Britt Donato, who is also a person in long-term recovery, started a business when she got clean. She used to come to the other Hope All Day, and she's going to be doing some paint parties, meditation. We also have John Jay, who's doing, I'm going to say it wrong. It's Kijong yoga. I don't know. It's like a yoga meditation thing. But it's really good. Supposedly, I didn't do it yet, so I don't know, but it's going to be really good. People like it. We also have pool tables, ping pong tables. You know, we have the fun stuff to do in recovery in between meetings, but we also right now have 6 or 7 12-step modality meetings that are meeting at different times at the recovery center. You know, one of the things that we did do, we did a picture mural timeline on the wall at the recovery center of the addiction recovery peer advocacy movement throughout our country. And it started in 1800s with the Washingtonians, and it goes all the way around the building. So it's very educational. You could come and do a little tour, and we also have a lounge TV, but we also have computer rooms. We're doing we're going to be starting up some resume classes, but we're waiting to get some people involved in that a little bit more. Some of the guys that are coming out of prison through Rutgers program will be utilizing some of the job resume stuff, but anybody can come. We always have a volunteer there. We have 2 computers with Microsoft 365. We have Word, Excel, printers. We have a library, reading library, quiet room. We also have a playroom for the kids. If you're a parent and you want to come to a 12-step meeting, you can also, your kids can use the playroom. You know, we're one of the things that we did this time that we tried to do last time but didn't have the space was we have a recovery gift shop. So anything that's recovery related, a lot of stuff from Hazleton, AA, NA, a lot of different tchotchkes and key tags and coins and medallions and anniversary cards, little sayings, T-shirts, recovery T-shirts. We have a couple of vendors from California that are donating some stuff, but that'll be open in the next couple of weeks. We also have another clothes Hope Chest, our clothes closet, which is free. So if you know somebody that, you know, just comes home from rehab or just came home from being incarcerated and you know, burned a lot of family bridges and don't have access to clothing, toiletries, come see us. Our food pantry will be open in the next month or so. We're waiting for the food pantry to come back to us because we were open at the other place. So we really want to try to get a lot of stuff done in the next couple of months. But if you need something, call 609-752-1877. That's my personal cell number. You call me and I guarantee I'll get it for you. If you need somebody to go to treatment, detox, housing, food, clothes, you name it, call me. Come see us. Hope All Day Recovery Center, 701 Route 50, Mays Landing. Come get some.
Chris, thank you so much. And thank you, Jen. And Chris, I know we're all very happy to know that, you know, Hope All Day is back, Hope Recovery Center. And if you want to put your information, put the address maybe in the chat box, just to make sure everybody has it. And I want to thank everyone today for, you know, speaking and presenting, and for all of our sponsors. And then also to all of the presenters and to everyone who attended. We really appreciate it. And, you know, it takes all of us to help reduce stigma and help people getting into treatment and help them in the recovery process. And we appreciate all that you are doing also in the community. So at this time, the evaluation link has been put in the chat box. So again, thank you for attending, and we hope to see you on June 23rd. Thank you.